everyone, and welcome to the P2 Network POCUS lecture series. My name is Catherine Pade, and I work at Rady Children's Hospital, San Diego, as a pediatric emergency medicine physician and ultrasound fellowship trained faculty member. Today, we're going to learn about pediatric point-of-care hip ultrasound. Our goals and objectives today: we are going to discuss indications, the probe we should be using, how to obtain the best images, the normal anatomy of the pediatric hip, pathology and abnormal findings, and we'll discuss some tips, tricks, pearls, and pitfalls, and then we'll go through an illustrative case. Hip pain in the limping child are common complaints in children presenting to the emergency department, accounting for approximately 4 in 1,000 visits. In particular, the diagnosis is often difficult in patients with no history of trauma, and it's important to distinguish between benign, severe, and life-threatening conditions. Some common differential diagnoses include septic arthritis, transient synovitis, also known as toxic synovitis, neoplasms like Kapp-Pearce disease, SCFE, avascular necrosis of the femoral head, among others. Several of these etiologies can cause a hip joint effusion that may be seen on ultrasound, and point-of-care hip ultrasound can help you narrow your differential. Typically, a high-frequency linear transducer is used due to the superficial location of the structures. In larger patients with thicker soft tissue layers, the lower frequency curvilinear transducer may be necessary. In order to obtain the best images, lie the patient supine with the hips in slight abduction, external rotation and flexion is tolerated, also known as the frog leg position. Expose the hip with a sheet or towel for patient comfort. With the patient lying supine, identify the greater trochanter on the anterior aspect of the symptomatic hip of the patient. Place the linear probe in the sagittal oblique plane parallel to the long axis of the femoral neck, with the indicator towards the patient's head. Locate the femur with its characteristic hyperechoic periosteum and posterior acoustic shadowing. Use the femoral head and the slanting neck as a landmark, and identify the hyperechoic fibrous joint capsule. The femoral neck is a hyperechoic line lateral to the femoral head, slanting downward. Move the probe superior until you identify the femoral head, which can be seen as a curved hyperechoic line. In the normal hip, the joint capsule appears as a hyperechoic band above the femoral head and proximal femoral neck. One tip in pediatric patients that have open growth plates: identifying the capital femoral epiphysis can help confirm you're in the correct location. The hip joint is formed by the articulation of the femoral head and acetabulum of the pelvis. The joint is enclosed by a fibrous capsule and surrounded by extracapsular ligaments. Normally, a small amount of physiologic fluid is present within the joint space, less than 5 millimeters. Measure from the concavity of the femoral neck periosteum to the outer joint capsule at the posterior surface of the iliopsoas muscle. The sonographic criteria for a pediatric hip effusion is an anterior synovial fluid collection greater than 5 millimeters or a greater than 2 millimeter difference when compared to the asymptomatic contralateral hip. So a tip here: compare the asymptomatic hip for anatomy and joint space measurement. Here you can see a large joint effusion. The joint capsule can appear more convex instead of concave with the presence of a significant joint effusion. Pearls and pitfalls. Pearls. POCUS can be used to guide arthrocentesis. The presence of a hip effusion cannot distinguish between a benign condition, such as transient synovitis, and a more serious condition, such as septic joint or osteomyelitis. Hence, clinical context and other diagnostic tests would be necessary to distinguish one from the other. An effusion can be heterogeneous or sometimes hyperechoic, especially when there's purulent material. Pitfalls. Too much pressure from the transducer can compress the effusion, leading to a false negative result. And cartilage over the femoral head may be mistaken as an effusion, as it is hypoechoic. A true effusion will cross the femoral head and extend along the femoral neck, while cartilage will not. Ultrasound has been shown to detect effusions as small as 1 ml with a sensitivity of 90 to 100%. And there have been several studies evaluating point-of-care hip ultrasound for the detection of hip effusion. Vieira et al. Found that emergency physicians detect hip effusions using POCUS with an 80% sensitivity and a 98% specificity, compared to the gold standard of radiology department ultrasound. And a retrospective case review by Barant et al. Showed that a POCUS-guided hip aspiration is both safe and feasible in the diagnosis of the septic hip in the pediatric emergency department. Here I present to you an illustrative case. So you have a 2-year-old male who presents to your emergency department with no significant past medical history, with a chief complaint of limp. The parents note he seems to be limping on his right leg. He has not had any recent fevers, and there's no traumatic witnessed event. On physical exam, he is afebrile, heart rate is 98, respiratory rate is 28, blood pressure is 90/60, and he's 98% on room air. On your physical exam of his right lower extremity, there's no obvious swelling or deformity, no tenderness deprivation of the entire lower extremity. However, he does have pain elicited with abduction and internal rotation of his right hip. Sensation is intact. His distal pulses are 2+, and there are no skin changes noted. On your differential, you would want to think about transient or toxic synovitis, septic arthritis, avascular necrosis, or osteomyelitis. So you perform the point-of-care ultrasound at the bedside, and here you know that you can tell just even eyeballing this that there is a pretty large joint effusion running along that femoral neck. You remember to measure the opposite side, and here you can see his right hip has a significant amount of more fluid than his left hip. Given the patient was afebrile, you gave him some ibuprofen with a significant improvement in his symptoms, and he was back to his professional golfing career. You discussed with the family that symptoms generally improve after 24 to 48 hours, with complete resolution of symptoms, often up to 1 to 2 weeks in about 75% of patients. You discussed strict return precautions with the family, which include any fever due to concern for possible septic joint or worsening symptoms. So in summary, the atraumatic pediatric hip pain has wide differential, and a POCUS can really narrow your differential. Emergency physicians can detect hip effusions using POCUS with an 80% sensitivity and 98% specificity. Remember, normally there's a small amount of physiologic fluid present within the joint space, less than 5 millimeters. So joint effusion would be if there is an anterior synovial fluid collection greater than 5 millimeters or a greater than 2 millimeter difference when compared to the asymptomatic contralateral hip. And consider using your ultrasound machine to help guide an arthrocentesis for diagnostic purposes. And I have attached my references at the end. Thank you so much for listening. So again, I'm Catherine Pade, and I work at Rady Children's Hospital of San Diego. And here's my contact information if anyone has any questions.